So with the studies available in the last 2 decades, now it is believed that we believe in the concept of utilizing the gut early in pancreatitis as opposed to the conventional NPO gut rest that was practiced decades ago. And nutritional therapy is crucial for restoring the mitochondrial damage and cell function early in pancreatitis. So the goals of nutritional therapy are to prevent malnutrition, and we know it's a catabolic state, to correct negative nitrogen balance, reduce inflammation, thereby improving the outcomes of pancreatitis. Nutrition in pancreatitis can be achieved through an enteral route or a parenteral route. Enteral nutrition can be provided through oral feeding or tube feeding in the form of a nasogastric or a nasojejunal tube. Besides meeting the nutritional demands or caloric demands, enteral nutrition has special non-nutritional benefits. They help in maintaining the gut barrier function, thereby reduce translocation of bacteria or endotoxins. Thereby, pancreatic infectious complications are less. It also increases the splanchnic blood flow, and gut motility also is increased or stimulated, thereby preventing bacterial overgrowth. Several studies have been performed to compare enteral nutrition and total parenteral nutrition over the years, and there are large meta-analysis. In Cochrane database reviews, conclusion on enteral nutrition is it has been shown to reduce mortality, systemic infections, multi-organ failure, and the need for surgical intervention in patients with acute pancreatitis. Hence, the standard of care today is utilize enteral nutrition in patients with acute pancreatitis. So first, let's look at oral feeding in patients with acute pancreatitis. Patients with mild acute pancreatitis, oral low-fat, soft or a solid diet is recommended as clinically tolerated. Conventionally, patients used to be started on a clear liquid diet, and they will be advanced as patients tolerate the nutrition. And oral feeding also need to be initiated independent of normalization of enzymes. Early institution of oral feeding has shown to reduce the length of hospital stay, and depending upon the timing of initiation of oral feeding, it can be classified as immediate, soon after admission to the hospital. And yearly oral feeding varies from studies to studies. Some studies have used the cutoff of 24 hours. Some studies have utilized the cutoff of 48 to 72 hours. And also oral feeding in response to hunger has also been studied recently. About 16% of patients with mild pancreatitis can develop oral feeding intolerance, which manifests in the form of abdominal pain, nausea, and vomiting. And it has been shown in studies that this feeding intolerance is not related to timing of initiation of feeding. However, a person with acute pancreatitis, when develops oral feeding intolerance, it can result in prolongation of hospital stay and can also increase admission into intensive care. A young male with active smoking and alcohol history, non-biliary etiology of pancreatitis, raised levels of blood urea nitrogen or hematocrit at admission, persistent SIRS at 48 hours, and presence of pancreatic necrosis increase the risk for oral feeding intolerance. Oral feeding is not always appropriate in patients with acute pancreatitis, and also the severity of pancreatitis is not a contraindication to start oral feeding. However, if patients do not tolerate oral feeds, enteral nutrition should be started within 24 to 72 hours, and the benefits of starting enteral nutrition are more pronounced when they are started within 48 hours. With regards to administration of tube feeds, two modalities are utilized, nasogastric tube and nasojejunal tube. Nasogastric tube does not require any training, so anybody can place it, the ease of placement. Only thing is the risk of aspiration is more with nasogastric tube. And the other downsides are patients with gastroparesis, gastric outlet obstruction, or duodenal obstruction preclude the use of nasogastric feeding. In contrast, nasojejunal feeding is associated with decreased gastric reflux, pulmonary complications, decreased incidence of nausea, abdominal distension, vomiting, diarrhea. The percentage of total nutrition that is provided, time to tolerate enteral nutrition, and the time to achieve nutritional targets are favorable in a person with nasojejunal tube, thereby ultimately resulting in shorter length of critical care stay and the need for ventilation. But what evidence do we have in guidelines? There has been a systematic review of 5 large RCTs which have compared nasogastric tube and nasojejunal tube. There is no difference in mortality, multi-organ failure, infection rates, need for surgical intervention or parenteral nutrition, depending upon the level of feeding in patients enteral nutrition is planned. As nasogastric tube is easier to place, convenient and cheaper, it is recommended as the first choice. 15% of patients who are started on nasogastric tubes do develop intolerance, and nasojejunal tubes are preferred in these patients. Aggressive enteral nutrition can be associated with abdominal distension. This can compromise ventilation and respiratory function. It can increase the intra-abdominal pressure, may lead to abdominal compartment syndrome in few patients. And aggressive enteral nutrition, especially because of the metabolic stress, especially in under-resuscitated patients, can lead to increased risk of development of non-occlusive mesenteric ischemia, as well as enteral feeding intolerance. Other complications that are noted in patients on enteral nutrition are abdominal distension, diarrhea, commonly encountered tube displacement or blocks. In patients who have enteral feeding intolerance, parenteral nutrition need to be started within 72 hours. There are certain situations where enteral nutrition is contraindicated. Patients with pancreatitis with an uncontrolled shock, severe acidosis, active GI bleed, gastric residual volume of more than a half liter in 6 hours, presence of abdominal compartment syndrome, or patients who have bowel obstruction, ileus, or ischemia, enteral nutrition is contraindicated. So what are the clinical impacts of yearly enteral nutrition? There's a small study which was conducted in patients with severe acute pancreatitis looking at effects of yearly enteral nutrition on intra-abdominal pressure. So in this study, the authors found that significantly lower rates of intra-abdominal hypertension in patients who were started on early enteral feeds. But the only downside was feeding intolerance incidence was higher in groups where early enteral nutrition was started. And they also observed that in patients who have an intra-abdominal pressure less than 15 millimeters of mercury, early enteral nutrition was tolerated. And they also felt that this could prevent the development of intra-abdominal hypertension. What are the guidelines say on nutritional strategy in intra-abdominal hypertension? Those who have abdominal compartment syndrome or very high pressures, enteral nutrition is not started. These patients are started on parenteral nutrition, and they are continued until the intra-abdominal pressure reduces. In other situations, patients are started on yearly nasojejunal feeds. It is important to start the feed slow, 20 to 25 ml per hour, and then advance to meet the caloric requirements as the patients tolerate. In patients who have enteral feeding intolerance, there is a concept of using a small volume of balanced enteral nutrition as a supplement to parenteral nutrition. Although this amount of nutrition is insufficient to meet the patient's nutritional needs, it is recommended to meet the non-nutritional benefits of enteral nutrition. With regards to the type of feeds, polymeric feeds are recommended as they are inexpensive, and studies have clearly shown that the elemental or semi-elemental forms have not demonstrated any added advantage when compared to polymeric feeds. The other clinical impact on initiation, timing of initiation with regards to outcome in pancreatitis, there was a large multi-center retrospective study from Japan looked at patients with severe acute pancreatitis. 3 time frames were looked into. One was patients where enteral nutrition was given within 24 hours, 24 to 48 hours, and patients in whom enteral nutrition was offered more than 48 hours. And the primary outcome was in-hospital mortality. And the authors found the significantly reduced in-hospital mortality when enteral nutrition was started within 48 hours. But when a subgroup analysis of less than 24 hours was compared with 24 to 48 hours, this difference in hospital mortality was not there. And they also found that yearly enteral nutrition within 24 hours in patients with severe acute pancreatitis, there's a higher risk of surgical intervention in this group of patients. This is one more retrospective study. This is a large retrospective database study from Japan looking at the effects of enteral nutrition started within 7 days. The authors found decreased 56% reduction in hospital mortality if they were started within 7 days. And there was 8.5 days reduction in the length of hospital stay in patients who were started on yearly enteral nutrition. Different types of feeding are also compared in trials. One is immediate oral feeding versus standard oral feeding. Immediate oral feeding meaning patients are started on nutrition soon after admission. Standard oral feeding is after resolution of symptoms and biochemical resolution. So, and they looked at length of hospital stay. Patients who were started on immediate feeding, they had a significantly reduced length of hospital stay. And the recovery also was found to be earlier in this immediate feeding group. Similarly, hunger-based nutrition oral feeding was compared with conventional oral feeding in patients with moderate to severe pancreatitis. And the results showed reduction in length of hospital stay in patients who were started feeding based on hunger. And the duration of fasting was also smaller in the hunger-based group. A meta-analysis of 5 RCTs was looked at to answer this question, timing of nutrition on length of hospital stay. But this study again compared the definition of yearly enteral nutrition in this was conventional feeding after resolution of symptoms. And they found significantly reduced length of stay in the immediate enteral nutrition group with a mean difference of 2.57 days. And patients who were started on immediate enteral nutrition had also reduced intolerance to feeding. So in patients who are started on enteral nutrition, it's important to remember that these patients can develop refeeding syndrome. Especially this is common in patients with alcohol-related pancreatitis because baseline these patients have malnutrition and delaying nutrition in them increases the risk of refeeding syndrome when the nutrition is started. So the recommendations are to start with reduced energy goals and increase slowly to meet the caloric requirements. Prophylactic provision of electrolytes, multivitamins, especially B1. Closely monitor clinically for signs of volume overload, heart rate, look at their hydration and biochemically monitor their electrolytes closely. So in conclusion, enteral nutrition therapy in acute pancreatitis is safe with low risk of complications. And studies have shown yearly institution of enteral nutrition is preferred because of reduced mortality, infection rate, local and systemic, and also the reduction in the length of hospital stay. In patients with mild acute pancreatitis, low-fat, solid or soft diet is preferred when in comparison to a conventional clear liquid advancement to solids. And in patients who have oral feeding intolerance, tube feedings are recommended within 24 to 72 hours. And studies have shown no difference in the level of feeding. So nasogastric tube, because of ease of placement, it is recommended as the first choice. And in patients who have enteral nutrition feeding intolerance or who have contraindication to enteral nutrition, parenteral nutrition is considered. Thank you for your attention.